Yes, everyone.
So, sir, it's 3, 2, 1. We are live to the audience. We can start this meeting. Over to you, Shailesh, sir.
Thank you. Good evening, everyone, and thank you for joining us today. My name is Dr. Shailesh from Philippines Medical Services team, and I welcome to this interesting webinar series called GTalk. The topic of today's discussion is more into role of Truecolor Pride in management of gastroparesis. And to present this, we have with us very eminent gastroenterologist from Kolkata, Dr. Debasis Dutta. Welcome, sir.
Thank you.
So, Dr. Dutta is the director of Fortis Hospital, Anandpur, Kolkata. Before we start, I'll take few moments to introduce sir. So, sir has completed training in gastroenterology and hepatology in London. He has also practiced as a consultant gastroenterology, hepatology, and internal medicine for more than 7 years in London, both in NHS and as well as in a private sector. He is currently overseas advisor for Royal College of Physicians, UK, India, and Dr. Dutta is actively involved in training of juniors as an educational and clinical supervisor. Sir has published several articles in gastroenterology in peer-reviewed journals and presented papers in many international conferences. And he is also an expert in gastroenterology, hepatology. Besides, he has special interest in therapeutic endoscopies, including ERCP, management of GI bleed, and endoscopy. So with this brief introduction, I request Datta sir to take over the session. Over to you, sir.
Thank you. I'll just share my slides. Can you see my slides?
Yes, sir. Now it's visible.
Hi, hello everyone, and thanks for joining this interesting session. We are going to talk about a topic which is not often discussed, gastroparesis and role of Truecolor Pride. This is not a new molecule, it's quite a molecule, and it's actually very, very effective in these conditions. So I will start with introduction. As you probably all know, gastroparesis is a very common gastrointestinal disorder. It was actually coined in 1958, quite a while back, when while doing a barium, Cassandra noticed that the barium did not leave the stomach in over 24 hours. And then the theory of gastroparesis started. It was started almost more than 60 years now. Nowadays, it's referred to a delay in gastric emptying that is associated with symptoms of nausea and vomiting. This is quite important because gastroparesis patients must have nausea and vomiting, and there is no mechanical obstruction. So it is a chronic symptomatic disorder of the stomach characterized by delayed emptying without evidence of mechanical obstruction. This is quite a common symptom in diabetes patients, which we often miss because we often do not sort of diagnose it. And affected patients have many interventions before actually they reach a diagnosis, and often the clinicians struggled to get a diagnosis. As the reason being, this is quite a poorly understood condition, could be quite debilitating, and it disrupts the personal life quite a bit. So before going any further, let's just very briefly discuss about the gastric accommodation and emptying. So this is the stomach, as you know, and there are two sort of synergistic effects. Effect of stomach accommodation, so the food gets stored properly, is due to nitrogen, and antral motility, which is often related to cholinergic. So these are the smooth muscle cells, and what we call are the pacemakers of the intestine are ICC, the Cajal cells. And because of the stimulation by the enteric neurons of the pacemakers, they actually stimulate the smooth muscle cells, and that's how the contractility starts. And the motility is mainly controlled in this part by the cholinergic nerves. So the reason that's important is because the drugs will act on those nerves to help. So what are the symptoms? Pretty straightforward. Patients will feel bloated. There is symptoms of early satiety. People will feel quite nauseous with postprandial fullness and symptoms of vomiting. This is quite important. Most patients will have nausea, fullness, followed by vomiting. Abdominal pain wasn't very common, but it's also seen that many patients, when the gastroparesis gets worse, abdominal pain is also there. And as I mentioned, vomiting after a few hours after having a meal is quite not uncommon at all. And what are the complications? You can see multiple complications. You'll be surprised that the patient presenting with dehydration. And if you take a careful history, they might have gastroparesis. On a long-term basis, they may have malnutrition. Their blood sugar levels can vary a lot because of vomiting and delayed gastric emptying. And the symptoms can sometimes be very difficult. So in a patient with severe diabetic gastroparesis, they may have quite a debilitating life because of the symptoms. What are the etiology of gastroparesis? Idiopathic is one, but what we are discussing today is mainly in patients with diabetic, but people who have post-surgical fundoplication and vagotomy, because it works on the cholinergic nerves, they may also have gastroparesis. And other conditions which we tend to forget, certain medications, especially opioids, can do it, certain antibiotics, antiarrhythmics, anticonvulsants. Neurological disorders, you will see in a lot of patients with Parkinson's disease, there's gastroparesis, certain post-viral infection, in kidney conditions, and rarely, which is often not recognized in scleroderma and ACN, you can get gastroparesis. So there are multiple reasons. However, diabetes is one of the factors which we often miss. So what is the pathophysiology? As was mentioning, there are in gastroparesis, there are quite a few things which doesn't work properly. The gastric fundus fails to relax, and the antral's distension, it can be quite severe because of pyloric spasm. So as the fundus is failing to relax, the antral distension happens, pyloric spasm, the stomach gets bloated, and in addition, there is visceral hypersensitivity, which can lead to discomfort also. So it's actually regarding really the motility of the stomach, which gets disturbed. The fundus doesn't keep it's not relaxing and causing more distension and visceral hypersensitivity. And for how do you reach the diagnosis? The main thing is delay in gastric emptying, but you got to sometimes do a procedure like an endoscopy to make sure there's no obstruction. And the typical symptoms I've mentioned already. But the diagnostic thing is with the typical 255 kilocalorie, low fat. This is quite important. Low fat meal, delayed gastric emptying is defined as retention or more than of 60% of the meal at 2 hours and 10% at 4 hours. So this is more or less the diagnostic. So if the food stays in the stomach, more than 60% of it at 2 hours, then it is almost diagnostic of diabetic gastroparesis. So what are the mistakes in diagnosing gastroparesis? A delay in gastric emptying that is not accompanied by typical symptoms by which I mean nausea and vomiting, early satiety, maybe due to just delayed gastric emptying. It's not gastroparesis. The stomach is actually emptying in these cases. However, it is probably emptying a bit slowly. But that doesn't give the diagnosis of gastroparesis unless the patient is having vomiting and unable to retain the food. And sometimes the predominant symptoms are those of dyspepsia, but there is no vomiting and nausea. These are possibly cases which we see very common, functional dyspepsia, mainly in younger population of 20 to 30. We're going to discuss the differentiation a bit later. So all patients who has delayed gastric emptying does not have gastroparesis. The patients who are actually unable to retain the food and are having constant vomiting and nausea is one of the main diagnostic criteria. So what are the other conditions which can mimic gastroparesis? I just mentioned functional dyspepsia is very common. Certain patients of psychiatric problems with cyclical vomiting syndrome can cause it, rumination syndrome. Cannabinoids can cause it. And as I mentioned, eating disorders, anorexia nervosa, bulimia nervosa, ARFID, they can have recurrent vomiting without actually gastroparesis. And as I mentioned, stress and anxiety and narcotic bowel syndrome. So there are other conditions which can mimic gastroparesis. So this is the ACG Gastroparesis Guideline, which came out very recently, 2022. And how do we diagnose gastroparesis? The strong recommendation is scintigraphic gastric emptying. That has been standardized as a standard test for evaluation of gastroparesis. Radiopaque markers are no longer thought to be diagnostic evaluation. People do wireless motility capsule test tool, maybe an alternative, but again, the scintigraphic gastric emptying is the investigation of choice for diagnosis of gastroparesis. So very, very briefly, what is it? diabetic gastroparesis is an autoimmune neuropathic complication, not due to mechanical obstruction. Uncontrolled elevations of blood glucose over a long period of time is the main cause. Why? Because it damages the nerve to the enteric nervous system. Subsequently, the stomach and the small intestine and the smooth muscles of the gut are unable to function properly. And this in the long term, as I've mentioned before, can lead to malnutrition and poor quality of life. And there will be patients who will need hospitalization because of recurrent vomiting and dehydration. So the epidemiology of diabetic gastroparesis, it varies a lot from country to country. It can happen from 1% to 65%. But what we know is prevalent usually in type 1 diabetes who are more than 40 years of age with more than 10-year history of diabetes. So it actually happens with people who have got uncontrolled diabetes for a quite long time. And interestingly, gastroparesis have been shown to be more prevalent among women, a cause we do not know. Again, a key recommendation in patients with gastroparesis, optimal glucose control is suggested the future risk of aggravation of gastroparesis. So there is a low level of evidence. However, one of the key recommendations we still say that to improve gastroparesis, good diabetes control is essential. And what else do we need to look into to manage gastroparesis? Nutrition considerations are very important. There are certain foods we've got to avoid, like high fat, high fiber, rich foods, greasy foods, alcohol, carbonated beverages. They should be avoided because they will cause delayed emptying more. Recommendations are the patient needs to eat frequent, small volume nutrient meals, and they need to chew the food properly. They have to walk or sit 2 hours before lying down. So never go to sleep after eating. Liquids, blended solid shakes and soup may have better absorption. So avoid high fat, high fiber, rich foods, but do take small amount of nutrient meals. There are multiple medications which can exhibit diabetic gastroparesis. The important ones are alcohol, opioids, and sometimes PPIs, which we use quite often. You see, there are a lot of patients with GI symptoms are on PPIs, but again, some of them might be making the gastroparesis worse, especially in diabetic patients. So this is something to keep in mind. However, the key is dietary management, which should include small particle of diet to relieve symptom and enhance GI motility. Now, this is a very important topic, how to differentiate between gastroparesis and functional dyspepsia. Before I go to that, there are multiple prokinetics which we are using in gastroparesis. The available agents, as you all know, metoclopramide, domperidone, erythromycin, clarithromycin are used. Sometimes we have used baclofen, and there are multiple drugs which are under evaluation. Some have small studies in levosulpiride and the 5-HT4 agonists, which we are going to discuss shortly. The difference between gastroparesis and functional dyspepsia, as I mentioned, can be quite challenging. However, in patients with functional dyspepsia, they may not be vomiting, as I mentioned. They may have predominant pain. However, due to gastric distension, gastroparesis patients may also have pain. So this is a very nice slide showing the pathophysiology of gastroparesis and functional dyspepsia. So if you look at that, there are a lot of common factors. But in a group of functional dyspepsia, there might be actually some rapid gastric emptying, which does not happen in gastroparesis. But in both of them, there is gastric dysarrhythmia, the problem in accommodation in the gastric fundus, there is problem with the discoordination are quite common. Another interesting part is sometimes if you take biopsies in functional dyspepsia, there may be eosinophilia, which is not present in gastroparesis. And how do you diagnose them? As I mentioned, scintigraphy is very, very, very commonly used. Breath test has got limited role. Wireless motility caps were used, but again, these are more for transit and doesn't help in the radiation exposures. So this is quite a busy slide saying the difference between gastroparesis and functional dyspepsia. You will see there are a lot of common factors in both the conditions, but interestingly, gastroparesis is less prevalent than functional dyspepsia. And the female to male preponderance is more in female, in functional dyspepsia, possibly in male. The age group is slightly different, younger in functional dyspepsia, I think more sort of elderly, as I mentioned, because it's usually the complication of diabetes for a long time. Cardinal symptoms are nausea, vomiting. They may not have vomiting, functional dyspepsia, but epigastric pain is there. In gastroparesis, there's loss of pacemaker activity of interstitial cells of Cajal, and some patients will have loss or damage to enteric nerves. Here, it's actually a disorder of the gut-brain axis, which you have heard quite often. Again, that also leads to impaired gastric accommodation, but there is sometimes low-grade inflammation. And as I mentioned, sometimes you will see high eosinophil levels. Diagnosis is usually by gastric emptying study, like a scintigraphy, and you have got a definite ROM4 criteria here. Dietary small frequency mode, which are actually very similar. Nutritional deficiency are common in gastroparesis. That is actually not that common in functional dyspepsia, but can happen. Regarding the medication, again, they're very similar, but more in functional dyspepsia, we are using acocciamide quite often. And there is a role of antidepressant. We do use drugs like citalopram, amitriptyline, mirtazapine quite often in functional dyspepsia. But again, the role here is more of a pro-kinetic agent, and we'll discuss about the 5-HT4 agonists in a bit. So there are a lot of common factors, but again, there are certain differences between the two conditions. So how do they work? What are the receptors there? And what are the drugs which were used for it? So for example, M1, you have heard about the cholinergic receptors. Acocciamide and etopride will work on it. On the dopaminergic one, metoclopramide, domperidone, levosulpiride, etopride, they also act. And the one which we are using more often now is 5-HT4. It's present throughout the GI tract and acts on proximal GI through acetylcholine release, and on distal GI by relaxing the circular muscles. And there are many drugs which we use. Tegaserot, cisapride has been used before, which is a non-selective 5-HT4 agonist. Truecolor Pride we are using very often now, which is a high affinity 5-HT4 agonist. And there are others like levosulpiride and metoclopramide, which has got some effect on 5-HT4. So these are the different receptors we work on, and we are going to discuss which more on 5-HT4 agonists. Again, treatment strategies, I mentioned this already. General measures, diet, nutritional support when required. Pharmacological is a prokinetic, which we often use. And antiemetic we can also use. And non-pharmacological, I will discuss in a minute. It's very similar to what I mentioned before. So this is another guideline of ACG Gastroparesis, which came out in the American Society of Gastroenterology guideline. So what they suggested is, first of all, you need to do a diagnosis. For a diagnosis, you need to rule out mechanical obstruction by doing an endoscopy or any radiological study. You can do a breath test. And after that, you may need to do scintigraphy to show there is delayed gastric emptying. The first line is dietary modification. As I mentioned, low fat, small meal, digestible food. With that, you try pharmacological treatment like prokinetics, antiemetics. Sometimes you need pain relief, followed by, again, if it doesn't work, you may need enteral nutritional support. And then comes the non-pharmacological treatment, which is now used in rare cases, but can be used. What are those? Pyloric botulinum toxin has been used. G-POEM or laparoscopic pyloroplasty has been tried. Gastrostomy, feeding jejunostomy has been done, and partial gastrectomy or sleeve gastrectomy. But these are the extreme cases when the initial bit doesn't work. But there will be a small group of patients who will need some kind of intervention. So what are the recommendations? Again, the ACG Guideline 2022, in patients with gastroparesis, we suggest treatment with metoclopramide over no treatment. This is low quality of evidence. In gastroparesis, domperidone is approved. Again, low quality of evidence. And we suggest use of 5-HT4 agonists over no treatment. Again, the quality of evidence is low. So you can use all of that, but it depends on which one the patient responds to. But regarding metoclopramide and domperidone, whoever has used metoclopramide, it can be quite useful, but it has got side effects of restlessness, drowsiness, and fatigue. And there are reports of extrapyramidal reactions, which we have probably all seen with metoclopramide. It can be associated with non-tardive dyskinesia, neurological symptoms. So you need to be cautious using metoclopramide on a long-term basis. So there are side effects which are often seen with clomipene. Domperidone has less side effects. However, there has been some small studies showing it can really cause abnormality of electrical activity, and it should not be used in patients in cases of serious heart condition. So there are sort of some adverse effects with both these drugs. So what are the other options? As I was mentioning, in treatment refractory gastroparesis, sometimes as a gastroenterologist, apart from doing intensive medical management, we have given jejunal feeding or even PEG drainage. And some people will need TPN. Rarely we go for pyloric intervention like pyloroplasty, and the newer endoscopic treatment like GPOM has also been tried. Pyloric Botox has also been used. The evidence is not very much, but there are certain patients who will benefit from it. Coming to Truecolor Pride, 5-HT4 agonist and its role in gastroparesis. Now, so what is 5-HT, 5-hydroxytryptamine? So 5-HT4 receptors are receptors in the gastrointestinal smooth muscle, LES sphincter, goblet cell, and enterocytes of intestinal mucosa. It is a modulator of gut motility and secretions. So what 5-HT4 receptors does, it promotes motility in the GI tract by circular muscle relaxation, longitudinal muscle contraction, and by that, it triggers the peristaltic, reflex, and colonic mass movement. So by doing this, it will improve the colonic transit and colonic emptying. It decreases the LES pressure and increases the gastric emptying. So it's actually a pro-motility agent, and it does by circular muscle relaxation and longitudinal muscle contraction. So these are where they are, 1 and 2. So these are alpha-2 adrenergic agonists, and these are the 5-HT4 agonists. So it works here, and by relaxing the circular muscle and contraction of the longitudinal muscle will improve the colonic transit. So Truecolor Pride is a very selective, high-affinity 5-HT4 receptor antagonist. The other prokinetics which are less selective are Mosapride, Cisapride, and Tegaserod. Cimetaprid is also one which works on 5-HT4, but also on 5-HT1 agonist. So what are the previous agonists which we used to use? Cisapride, we used to use it quite a lot in 1990s, but unfortunately it was associated with cardiac arrhythmias, and we have stopped using it. It was withdrawn from the market in 2000. Tegaserod also, we have used it for IBS constipation. It was again withdrawn in 2007 with problem with ischemic cardiovascular event. So this partial HT4 agonists have been removed. Now, Truecolor Pride is a different story completely. It's a highly selective 5-HT4 agonist, and there is no interaction with other receptors like 5-HT3 or 5-HT1, and it stimulates gut motility by interacting with 5-HT4 receptors, resulting in acetylcholine release from cholinergic neurons. And it helps in the overall colonic transit, as I mentioned, and by increase in the proximal colon emptying has been observed. Truecolor Pride also improves motility in proximal colon. It has action on distal colon, and it has also action on LES stone. So it has got multiple actions, mainly, as I had mentioned, by helping the motility of the gut. Now, this is a very, very nice study which came out in 2016 in Neurogastrogen Motility, which actually showed effect of Truecolor Pride on colonic contraction. So the study was done with Truecolor Pride and PEG 3350. It was a small study. What they looked at is a high amplitude propagating contraction. And if you see both, the black one is Truecolor Pride and the white one is PEG 3350. The frequency of giant and amplitude contraction in the colon was much better, and there was also amplitude velocity was much better. So though a small study, it actually showed that the function of Truecolor Pride was much more effective than a PAG 3350. And again, very similar effect on colonic transit time. Study with 280 patients, 93% of them were women, mean age was 43, and duration of constipation was very long, 19 years. There were 2 doses used, Truecolor Pride 2 milligrams and 4 milligrams and placebo. And you can see that the change was very significant. In the placebo group, there was actually a slight increase in the colonic transit time. But if you look at Truecolor Pride 2 and 4, they were all very similar. There was a significant decrease by about 12 hours and 13.9 hours, respectively. But statistically, 2 and 4 milligram did not show any difference. So this study showed that Truecolor Pride has improved colonic transit time significantly. Now, the worry which was there with the Truecolor Pride before and later Tegaserod, QT prolongation. In Truecolor Pride, there has been multiple studies which has shown there is no interaction with the potassium channel or the 5-HT1B receptor. So compared to Truecolor Pride and Tegaserod, there's actually no risk of QT prolongation with 5-HT4 agonist Truecolor Pride. They actually use a supratherapeutic dose of 10 milligram instead of the therapeutic dose of 2 milligram. Again, there was no problem in the QT prolongation group. So till date, 5-HT4 agonist Truecolor Pride has been found to be quite a safe drug from the cardiac point of view. These are the multiple studies. I won't go through it. Mainly 2 milligram or 4 milligram has been used, and all the studies has actually shown that the bowel motility was much better within a week. And 2 milligram and 4 milligram did not make a huge difference. So nowadays, as you know, we are using 2 milligram dose on a regular basis. I'm going to quote this another study which came out in New England Journal of Medicine in 2008. Truecolor Pride for chronic constipation. So primary efficacy endpoint was having more than 3 spontaneous complete bowel motion. This is quite important. More than 3 spontaneous bowel motion in a week, averaged over 12 weeks, 3 months. Secondary was derived from daily diaries and validated questionnaires. So if you look at this, 2 milligram, 4 milligram, and placebo, you can see there was a significant difference in Truecolor Pride within the first 3 months. Actually, the difference was in the first 4 weeks, then 5 to 8 weeks, 9 to 12 weeks. So over 12 weeks, 69.1% of patients receiving 2 milligram propylglycol had an increase of more than 1 per week spontaneous bowel movement compared to 36% in the placebo group. So there was a significant difference in Truecolor Pride. The patient's constipation actually improved over a period of 12 weeks. This was the big study which actually helped patients, helped doctors to convince that Truecolor Pride is useful in constipation. And the study was phase 3, and the numbers were quite big, 620. Again, looking at here is Truecolor Pride, the treatment of chronic constipation in patient dissatisfied with laxative. That's also quite important. So the quality of life improvement. If you look at this, it was a phase 3 RCT, 713 patients. And if you look at the quality of life significant, this is the one with the placebo, 2 and 4 milligrams, significant increase from 20% to 45 to almost 50% improvement in bowel function. And the patients felt that the quality of life was much better. Now, moving on from constipation, I will go to the next bit of Truecolor Pride. Truecolor Pride in gastroparesis, a randomized placebo-controlled crossover study which came out in Gastroenterology, American Journal of Gastrology in 2019. This was also a landmark study. They used Truecolor Pride. It was a double-blind, randomized, placebo-controlled crossover study, about 34 patients with gastroparesis. So they used Truecolor Pride in group 1, and then used placebo. There was a washout period. The Truecolor Pride people got placebo, and the placebo got Truecolor Pride. And they were screening initially 4 weeks, 2 weeks, and 4 weeks. So the study was very well matched. I think with the female, male, age, BMI ratios, it was all very well matched. And data are separated into 2 groups according to the sequence of treatment, results in the total patient group, results in the idiopathic patient group, and gastroparesis group. And what they saw is quite interesting. So if you look at the run-in period, placebo period, and the Truecolor Pride period. So this episodes of nausea and vomiting improved with Truecolor Pride, so did fullness and satiety, so did bloating, distension, pain, lower abdominal pain, and reflux. So compared to placebo, Truecolor Pride did better in all of them, but statistically significant was nausea, vomiting, fullness, bloating, and reflux. Pain did not change that much compared to placebo, wasn't statistically significant, the rest four were. And if you look at the daily activity, improved with Truecolor Pride, clothing got smaller, diet improved, psychological function also improved, relationship improved, and in total, there was a good improvement of quality of life. So what achieved statistical significance was total quality of life, and the patients could use less heavy clothing. So there was definitely an improvement in upper GI symptoms and quality of life in Truecolor Pride in diabetic gastroparesis. And this is again with solid emptying was also better. Safety, which was very important. Only one serious event occurred. One patient developed intestinal volvulus 18 days after the start of treatment with Truecolor Pride. Adverse event determination was one case with diarrhea and one with headache, and a case of nausea during placebo treatment. Transient diarrhea was reported by 9 patients, lasting 1 to 7 days, and in 1 patient during placebo treatment. So it was actually quite a safe drug. There was only one incidence of volvulus. The study summary was Truecolor Pride significantly improved the total gastroparesis cardinal syndrome and the subscales of fullness, satiety, nausea, vomiting, bloating, and distension. It significantly improved the overall patient assessment of upper GI disorders, that means the quality of life and domains of clothing and diet. And the gastric half emptying time was significantly enlarged by Truecolor Pride compared to placebo and baseline. So this was a 4-week study which actually showed Truecolor Pride treatment significantly improved symptoms and quality of life by enhanced gastric symptoms. So we have shown 2 studies. One showed improvement in constipation for giving over 3 months. And this is a study only for 4 weeks, which actually showed within 4 weeks, Truecolor Pride improved in patients with gastroparesis. This is again came out in 2019. Mechanism underlying symptom benefit with Truecolor Pride in gastroparesis. They hypothesized that the stimulatory effect of Truecolor Pride on gastric motor function improved both accommodation and the phasic contractility, which improved the beneficial effect. So as I mentioned in the pathophysiology, there was a problem with the gastric accommodation and pyloric spasm and lack of contractility that improved with Truecolor Pride. Now, what about the pediatrics cases? Unfortunately, there aren't many cases no studies with gastroparetic children in pediatrics. This is a study which came out in an 8-year-old boy. He did not improve with metoclopramide, domperidone, erythromycin, esomeprazole. Received Truecolor Pride at a very low dose of 0.03 to 0.4 milligram per kg body weight, and it showed there was some improvement. But this is just one-off study which came out in the paper. Again, another case report with novel therapy. They did show some good response, but more studies are required in pediatric population with Truecolor Pride. Coming to a very important disease, where there may be a role of Truecolor Pride, is Parkinson's disease. You will see many patients with Parkinson's disease who are unable to eat properly and are having symptoms of nausea and vomiting. So this is a research article on effect of Truecolor Pride on gastric emptying in Parkinson's disease patients, a pilot randomized open label study. There were 10 patients were given Truecolor Pride 1 to 2 milligram daily or domperidone, and scintigraphic gastric emptying for solid meal were observed. And if you look at the 2 groups, this is the domperidone Truecolor Pride group and the Truecolor Pride domperidone group. Again, very similar. So this is the Truecolor Pride group, domperidone group. And what they found that there is good efficacy of Truecolor Pride in accelerating gastric emptying in PD patients. It was a very small group of patients, and there was not much difference between 1 and 2 milligram, but they found that it is probably better than domperidone in accelerating gastric emptying. What about in patients with connective tissue disorder? There was an article which came out in Neurogastrogen Motility very recently. Again, they did very similar crossover study, a double-blind crossover study in diabetic or connective tissue disorder patients. from 2 crossover studies, they said Truecolor Pride at a higher dose of 4 milligram accelerates gastric emptying and bowel movement frequency, but does not seem to ameliorate gastroparesis and meal-related symptoms. So it does improve to a certain extent, but it's not proven. And you must note that the dose used in the connective tissue disorder are quite higher at 4 milligrams. So I've come to the end of my talk. In summary, Truecolor Pride is a third-generation, highly selective 5-HT4 receptor agonist. Many recent studies indicate Truecolor Pride may play an important role in various motility disorders. Its high selectivity for 5-HT4 receptor has a very favorable stability profile and no concern for cardiovascular problems. As I mentioned, they tried a very high dose of Truecolor Pride. Again, there was no problem with the QT interval. And Truecolor Pride also has the potential to be useful in the treatment of functional constipation, as I've shown with a very nice New England Journal study, and other forms of gastrointestinal diseases like gastroparesis, which was shown in the American Journal study. But through the research on this potential, Truecolor Pride is expected to be a very useful and versatile option for treating gastrointestinal disease in the future. We are using it on a standard treatment, and we have found this to be a very safe drug, where we are using it quite often in patients suffering from functional constipation and some patients with upper GI motility disorders. Thank you very much.
Thank you so much, sir. It
Thank
was
you.
indeed a very insightful session. So we have received several questions. So I'll just read out the questions for you. So the first question was on the link between the functional dyspepsia and gastroparesis. The question is there any overlapping between functional dyspepsia and gastroparesis, particularly in T2DM patients?
Yes, there will be an overlap. I think there will be some patients with functional dyspepsia will also have gastroparesis. But what I'm trying to say, the predominant symptom in gastroparesis will be nausea and vomiting, which we often do not see in functional dyspepsia. And they often present with pain, bloating sensation, but not that often vomiting. Yes, there will be an overlap. In certain diabetic patients, they may have functional dyspepsia also.
Okay, sir. Sir, on the similar line, we have a question from Dr. Majumdar from Siliguri. So he is also saying that most of the geriatric patients with diabetes for years, they often come up with the symptoms of gastroparesis. And is there any confirmatory test, like particularly in geriatric patients, how to diagnose this, and what is the actual burden in your routine practice about these kinds of patients?
It's a very good question, actually. Practically, it's very difficult to do things like scintigraphy to diagnose gastroparesis. So I think there's a lot of clinical element which comes in. So if a patient with a long-standing diabetes, not well controlled, having constant symptoms of nausea and vomiting, they may have gastroparesis. What I will usually do is do an endoscopy to make sure there is no obstruction, mechanical obstruction, and then try with the prokinetics which you have got in store. And I personally feel that if you have actually got a diabetic patient for a long duration having these kind of symptoms, there's no harm trying this prokinetics. Truecolor Pride should be a good drug to try in these cases. But I will always do an endoscopy to make sure there's no obstruction, because sometimes they will have other pathology which can cause nausea and vomiting.
Thank you, sir. So there's one more question on Truecolor Pride, which suggests that can Truecolor Pride be used as a prokinete drug in patients not responding to other drugs such as levosulpiride?
You see, there are not much evidence on that yet, I must say. There hasn't been many studies, but there is no harm trying, because there is absolutely no doubt, especially in functional constipation, IBS-C, Truecolor Pride works very well. And there is no doubt that there is some element of help in the upper GI motility also. So I am not a great fan of levosulpiride because I don't use it for a long duration, because it has got some effects on the nervous system. So if I give you levosulpiride, I will use it on a very short-term basis. Truecolor Pride hasn't got that much of a side effect, so I will be more than happy to use it at least for 3 months and see how the patient is. Okay.
So there's a question on future. So like, what are the newer drugs which may see in the near future for gastroparesis?
There are many studies going on, and I think you see most drugs haven't functioned very well. If you look at the Truecolor Pride study also, there's only about 10-15% benefit. So that's why the question of other sort of endoscopic procedures like pyeloplasty, GPERM has come in. But again, I will try different modalities. Different people react with different modalities. But one thing important to remember is it is not only medication. It is also the diet what they're taking. So the low-fat diet, small frequent meals, sort of walking and not going to bed immediately after eating. So certain things, doing exercise, certain things apart from drugs. So it's not only taking a pill, but also thinking about your diet, thinking about your lifestyle, which will help the patient.
Okay. So there is one more question on Truecolor Pride. Is there any role of Truecolor Pride in IBS-C?
Yes, of course, there is. There is a good study which actually shows. I've shown one from the New England Journal.
Okay.
I'll be very happy to use Truecolor Pride 2 milligram for at least 3 months and see how the patient benefits.
Okay. And sir, regarding the pharmacotherapy, that once we start Truecolor Pride, so is there any need to discontinue the existing drugs? Because for constipation, the approved indication is laxative resistant constipation. So do we need to discontinue the existing drugs?
No, I don't discontinue. I think sometimes the combination works better. I think you might need to add a laxative or something to it and maybe take it as and when necessary. No, I don't discontinue it completely. So I will continue Truecolor Pride and give them the option of taking the laxatives if required in addition.
Okay. And sir, regarding since gastroparesis is also more common in women, so is there any change in efficacy, particularly in women Truecolor Pride? Have you observed anything like that?
No, there is no definite proof that there is, but no, I haven't observed definitely that there is anything different in women. But again, long-term type 1 diabetes and poorly controlled is one of the factors which we have to see quite often.
Okay. So there's one more question just popped up. So can we use Truecolor Pride as a colon cleansing agent before colonoscopy?
No, not as a colon cleansing agent. It works slowly. It improves the contrality. No, for before a colon cleansing agent, you might have to use something strong.
Okay. So I think, sir, I'll just check if there is any more question on the link. So as of now. No, so there are no, yeah, there's one more question, particularly on safety part. So can we use these drugs safely in CKD patients?
Yes, I have used it in CKD patients also.
Okay.
I think keep monitoring it. There aren't any big studies showing that it is harmful in CKD patients.
Okay. Yes, so that's the end of all the questions that we have received till now. So thank you so much, sir, for your valuable time. And
Thank
on
you.
behalf of Lupin, we are thankful to Dr. Dutta for his time, as well as discussing all the important points about Truecolor Pride and gastroparesis in detail, and also answering all our questions very patiently. We are also thankful to each one of you who has participated and who have joined this webinar from different places. So thank you once again, everyone. And thank you so much.
Thank you, Dr. Shailesh, and thank you for everyone joining. Thank you.
Thank you, sir. Bye.
Thank you very much.
Thank you, sir. So with your permission, shall I close this meeting?
Yes, sure. Thank you.
Yeah, thank you, sir. So from here now, I'm ending this meeting. Have a great evening ahead.
Thank you, everyone. Thank you.